So I hope you enjoy the lunch during the lunch break. So it's almost time. We're going to start. But before I start, once again, I want to share a little bit of a story about the things that we prepare for everyone. Well, for most of the people. So if you receive a bag, you will find this tea in your bag, maybe in different shape or different form. So it comes with a story. The brand is called Shanbuku, and it's created by a faculty member and 5 master students from the Institute of Building and Planning at National Taiwan University. The story is simple. The professor went to a place called Pingling and found that they have a recession in their economy. So he tried to revitalize their tea industry. And to do that, he brought in students to do classes and internship there. And eventually, they developed this brand, helping the local people, the farmers, to sell and then to produce their tea and sell it to everybody. So from that story, we thought it was very meaningful because it was about the local economy, it was about caring for the local people, and because they try to minimize the use of pesticides, it's also environmentally friendly. And everything together that coincides with the spirits of public health. And that's why we included the tea as a souvenir. Thank you. So we will have 2 more sessions in this afternoon. This session will be moderated by Professor Chen. Professor Chen received his doctorate degree in health policy and resource management from School of Medicine at Yale University. He has served at the Taiwanese Bureau of National Health Insurance and was awarded the Health Medal from Department of Health under Executive Yuan. He's also now the Associate Dean of the college. We're very pleased to have him to host the session, Skin Disease in an Aging Population, a Silent Growing Epidemic.
Thank you, Anzhen, and welcome back. This is the first session in the afternoon. You may take a look at the first speaker. We have 2 speakers. The first speaker is a little bit strange to us and maybe mysterious to most of us. And his name is Benjamin Zhong. And Benjamin is not just like a dermatologist. He's also a social professor at the University of Texas. And about more his individual information. He promised that he will give you a little bit surprise. So let's welcome Professor Zhong.
Thank you, Professor Cheng. I really want to thank the Preventive Medicine Foundation and Professor Chen and the organizing committee for having me here. I am certainly very humbled to be part of this distinguished group of guests. Is there a pointer? Oh, here we go. Okay. Yeah. Oh.
Would you just please tell them to do that?
Okay. Okay.
And meanwhile, I'll find a clicker.
Sure. So I happen to be part of this conference, and if you could just go to the next slide. And my grandfather is KP Chen, and so I'm certainly very honored to be here. And this is, and I think we've mentioned a lot about my grandfather. He has certainly left a lasting legacy to the people of Taiwan and the people of this world, but also to our family. And he was the one who inspired me to become a physician and to try to impact as many people around him as he could. And so this is a picture of our family when I went to visit Taiwan at an early age. I only met my grandfather when I was less than 1, but obviously learning a lot about him has impacted me as who I am now. This is my mother, who is on the right side, and she's the only daughter of KP Chen. And that's me just next to her. And then my father and my grandmother on the left side, and then my younger brother Linus, who is now a dentist in Los Angeles. Next slide. So my parents came to the United States to pursue further schooling in the 60s, late 60s and early 70s. And we first, actually, after they got married, they moved to Washington, D.C. Next, if you just hit the next thing. Sorry, next slide thing. Yep, okay. And that's where I was born. And then we moved to Los Angeles, next slide. And that's where I had my formal schooling education, and then actually had the chance, and I want to thank again my parents for letting me have the chance to be at Harvard University when I was in as an undergrad. Next slide. And then eventually moved over to Johns Hopkins University to do my school, to pursue my MD. And then after that, I became a dermatologist and trained, next slide, at Detroit, Michigan at Henry Ford Hospital, where I was chief resident there. Sorry, next. One more. Oh, okay, good. And then finally moved down to Dallas, Texas. Let's see. Oops, good there. Okay, there we go. Dallas, Texas, and then this is my family. This is my wife, Debbie, who's actually a retina surgeon, and she actually is a Harvard Med School graduate. We met at Harvard. And then these are our 3 children, Ellie, who's 8, and then our twins, who are 4 years old. All right, oh, okay, sorry about that. Okay, so I am currently an academic dermatologist, and kind of like my grandfather, really wanted to be in academic medicine to be able to do a lot of different things. I currently do clinical and translational research in cutaneous lupus, which is an autoimmune skin disease associated with systemic lupus patients. I also teach medical students and also train dermatology residents, and that's one of the joys of my profession, is being able to train the youngest minds and who have a lot of energy. And then I also do patient care as well. Sorry about that. I'm still trying to figure out this. Okay. My research is actually centered around a registry of patients focused on cutaneous lupus, and I started this about 9 years ago. And this is a longitudinal observational study of almost 300 patients where we collect clinical data and biospecimens from patients over time. And what we're interested in is trying to understand the clinical course of this disease, and also try to improve how we diagnose, prognosticate, and then better manage these patients. And as you can see on this table on the right, I actually have quite a bit of patients from different backgrounds. African Americans actually make up most of our patient population, but we also have a mix of other ethnicities and races involved as well. My research is actually centered on trying to improve and outcome measures for clinical trials in cutaneous lupus, which really there aren't very many of those. They're either now either patient-focused or patient-reported outcome measures or physician-reported outcome measures. We've also been interested in looking at serum biomarkers as objective measures for disease activity, and then also been very interested in trying to understand the immunopathology of cutaneous lupus. So I was asked to kind of talk a little bit something different in terms of my background, and to talk a little bit about the epidemiology of skin diseases in the aging population, and how that actually is a problem that isn't really well known or characterized, but it is a growing issue that I'd like to illustrate. I'd also want to talk a little bit about just some of the common skin problems that are seen in the aging population, namely skin cancers and infections. And then finally talk a little bit about strategies for skin disease prevention. So my mentor, Henry Lim, who was my chairman during my residency program, initiated a task force in the United States, and they were actually interested in looking at the burden of skin disease in the US. And they published a paper that just came out in our dermatology journal, our top dermatology journal, looking at patients who had a skin disease and didn't. And this graph from that manuscript actually breaks down the percentages of patients with a skin disease by age group. And you can see in the kind of in the largest population is people who are 65 years and older. Almost about 50% of these patients have that. And that doubles the amount, percentages in the, compared to the patients from the other age groups. So they also published a kind of accompanying manuscript looking at what type of skin diseases were people getting. And so this is a graph that actually shows just the percentages of patients who are afflicted with a certain skin disease, again, by divided by age group. And you can see that this is actually the highest amount of people with actinic damage, as well as skin cancers. Connective tissue diseases is another type of growing skin problem. And these skin diseases can actually increase up to 14-fold with age. So some of these actually skin diseases can result in death. And most of them are usually from skin cancers, which we typically divide into non-melanoma skin cancers and melanomas, and as well as infections. And this is a graph that kind of is a pie graph that depicts just the different types of skin diseases that people can die from. Skin cancers take up about 60% of the skin diseases that result in death, and then infections contribute to about another 10%. So in terms of skin cancers, they actually, there are a number of risk factors that are associated with skin cancers, and this is typically related to sun exposure, because ultraviolet light is a risk factor, or can contribute to the to the development of skin cancers. People who are immunosuppressed, typically because of the medications they're on, if they have a history of radiation exposure, if they have a strong family history of past skin cancers, if they have fair skin, so typically these are patients who have, who typically burn when they're outside but they don't tan, if they have any sort of exposures to viruses, namely papillomaviruses, and then finally indoor tanning boosts, which is a very popular activity, especially for younger people, have been also associated with the risk of higher risk of skin cancers. So non-melanoma skin cancers typically make up 98% of all skin cancers, and the main ones that we are usually concerned about are the basal cell cancers and the squamous cell cancers. And they can come in different types and forms. The basal cell cancer is, this is an example of what we call a nodular basal cell cancer, which can be somewhat dome-shaped, has these pronounced blood vessels, and these are often found in sun-exposed skin. There's a superficial type, and then there's also squamous cell cancers, which typically are a little bit more scaly, rough-looking. They can often ulcerate, or the skin is gone. And fortunately, most of these cancers don't spread to other parts of the body, but for squamous cell cancers, typically about 5% of them can metastasize, typically most often to the lymph nodes. Basal cell cancers can often metastasize, but that's usually about less than 1%, and they can go to the lymph nodes, liver, lungs, pleura. So the diagnosis is typically made by doing a skin biopsies, and then there are various treatments that we use, including surgical excision, or a surgery called a Mohs surgery, which is basically a tissue-sparing surgery that we usually reserve for patients who have skin cancers in sites like the face, where you don't want to take too much skin off. There's also another treatment called electrodesiccation and curettage, which is a scrape and burn method used for more superficial cases of skin cancers. Radiation is something that can be used for squamous cell cancers. And then for conservative treatments, there are topical treatments that are used. These are 5-FU is a chemotherapy agent that we often use for these skin cancers. Melanoma is the more serious type of skin cancer. It's a tumor from melanocytes, or pigment-forming cells, that are at that can spread very quickly to other parts of the body. They can come from pre-existing moles, and that's usually about 50% of those cases, but the other 50% really can just come on its own. It's a most common cancer or cause of death in patients who are females, particularly in the young age range. And they can also, when they first begin, they have this horizontal where they kind of grow out and spread out in the skin, and then finally they have a vertical growth where they actually spread deeper into the skin, and that's where the chance of metastasis grows. So the diagnosis is again made by skin biopsy. Treatments are very similar. Treatments are very similar as well. in terms of just trying to diagnose how melanoma works, we actually have a tool which we call the ABCD criteria. A starts for asymmetry, which means that one side doesn't look like the other. B is for border, which means that if the border is rather jagged instead of nice and round. C is for color, again, if one side of the mole doesn't look like the other side. And then finally, D is for diameter, which again, if it's bigger than 6 millimeters or size, that's something to be concerned about. So in terms of the biopsy, one of the things that we looked at when we do a biopsy is, does it have other features? Like, does it ulcerate if the top layer of the skin is gone? How deep is it? Are there actually presence of metastases? These are things that we use to try to determine what's the staging of this disease. And then, of course, since it can spread to other parts of the body, other things can be done like a sentinel lymph node biopsy to check the lymph nodes. And then CT scans or MRI scans can be indicated to look for other areas of involvement. The treatments besides excision are actually now more revolutionized because there are targeted therapies that are typically more effective and better tolerated. These can be ones against CTLA-4 or BRAF. In terms of infections, there are multiple sources of infections that can occur in the aged population. What we're going to focus mostly on today is bacteria and viruses, but fungi and atypical mycobacteria are other important sources of infections that can result in significant morbidity and mortality. So bacterial infections in this group typically are from gram-positive bacteria or staph or strep, and the clinical presentation in these patients can vary depending on the depth of involvement. So, for instance, pyoderma is a limited skin involvement where they just have these erythematous or red nodules or plaques that can be painful and can drain pus. But typically, these patients don't have much in terms of their systemic symptoms, like fevers, and they can be treated with oral antibiotics and topical antibiotics. But when you reach the stage of cellulitis where it's more involved, it usually affects one extremity, one side, they do recommend actually more aggressive treatments, which is intravenous antibiotics. Viral infections are also varied, and I'm going to actually just focus on the herpes infections, viruses, because they can also cause a significant amount of morbidity. Herpes simplex is usually seen in the oral labial areas or the genital areas, and that can be either due to HSV1 or HSV2. These are usually preceded by a prodrome with fever or lymphadenopathy, but also can have significant tingling or pain before the skin rash actually comes out. Herpes zoster is a little bit more affects a little bit more of the larger part of the body, typically one dermatome, and also is preceded by significant pain. And once the eruption goes away, the pain can be very significant, and it can last for several years after the rash is gone. The diagnosis for this is typically used with a bedside technique called a zinc smear, but now we can do swabs to do PCRs to identify these viruses. And the treatment typically are these antiviral treatments, including acyclovir and valcyclovir. So in terms of strategies for skin disease prevention, they're really focused on trying to, these are just strategies that I've recommended based on just the prevalence of skin cancers that are seen in the aged population, and then also for infections. So I'm going to first talk about photoprotection. Photoprotection can come in kind of various forms, including application of sunscreens, wearing long sleeve clothing, wearing hats, wide-brimmed hats, and then also carrying dark umbrellas. And the sunscreen tips that I usually recommend for my patients are mostly focused on whether they have a sun protection factor of at least 30, and then whether they actually have broad spectrum. And this is actually important because broad spectrum means that they cover both ultraviolet A and ultraviolet B. And the sunscreens I like typically contain physical blockers, which are effective in blocking ultraviolet A and ultraviolet B. But they are kind of more, they tend to be white and pasty, which many of my patients don't exactly like because of cosmetic reasons. When you're going outside, we recommend putting it on 15 minutes before you go outside and reapplying every couple hours. And this is really, we recommend using sunscreen daily, even if they're just doing their daily errands, because for particularly high-risk patients. Sunscreen use has been linked to an 18% reduction in melanoma cases, and this was based from a study out in Norway, where they actually looked at 140,000 cases and detected about 700 melanoma cases and looked at their sunscreen use as well. So in terms of sun protecting clothing, I've used my family as an example of good sun protection clothing techniques. They usually have an ultraviolet protective factor that's associated with that, and that can depend. This is, we recommend something or 30 or above, and that can be based on the fabric, the type of fabric that's used, and also what color, which because the darker colors, like my son is wearing right here, typically blocks out UV better than others. Wide brim hats are also recommended. Sunglasses are good, and dark umbrellas can be also helpful for sun protection. Now, in terms of skin checks, we do recommend them, especially for high-risk patients. We recommend monthly skin checks. Typically are helpful, and you can use the ABCD rule that I kind of mentioned earlier. And then for providers, we also, for doctors, to also do full skin body checks. And usually we recommend at least once a year for the high-risk patients. And then we recommend even more frequently for patients who've had a recent history of skin cancers, because these patients who have skin cancers, they're at higher risk of getting more. In terms of infections, we recommend good hand hygiene, which I think many of you are familiar with. Hand sanitizers tend to be a little bit more effective. And then the antibacterial treatments that we also recommend. I will prescribe antibacterial washes to help with cutting down any sort of infections. And then I also will prescribe something called topical mupirocin. And these are important for patients who actually have recurrent methicillin-resistant Staph aureus infections. And what we'll do is we'll have them apply it inside their nose 3 times a day for the first week of each month. And that's been helpful for reducing the reinfection rate. As many of you know, vaccines are very important for prevention of disease, and particularly for the skin perspective, they've been very helpful for herpes zoster. There are 2 forms of zoster vaccines that are used, the live attenuated vaccine and the ink inactivated recombinant vaccine. The live attenuated vaccine has been out there for years. It's approved for patients 60 years or above. It's 1 subcutaneous dose, and the efficacy studies have been modest. About 60% patients have noted efficacy or prevention of shingles, but the efficacy or protection seems to decline 8 years after the vaccination. The FDA in the US has recently approved a new vaccine. It's an inactivated recombinant vaccine, and this is now approved for a larger age group for patients who are 50 years or older. It is 2 intramuscular doses spaced 2 months apart. And the efficacy from these studies have been actually in the 90th percentile range. And this has also been nice for some of our patients because it's been also recommended for use for our immunocompromised patients. And this is particularly helpful for my patients who are on a lot of immunosuppressive medications because I take care of patients with autoimmune skin disease problems. So I want to conclude by just stressing the importance of skin diseases. Skin diseases do increase in patients in the aged population. Skin cancers and infections are common causes of skin problems in the aging population. And strategies including daily photoprotection, vaccination, regular skin checks, and antibacterial washes and ointments can be helpful in preventing skin diseases in this population. Thank you.
Okay, thanks a lot. It's quite interesting, right? Many of the slides I can recognize. What type of skin cancer? Well, that's professional. Okay, next presenter is Dean Emeritus Fukuhara from Kyoto University. and he has received his clinical training in UCSF, and then received his clinical epidemiology training at Harvard. Of course, many of us here from Harvard. And his research goes beyond clinical practice. He did clinical evaluation and health service research. So let's welcome Professor Fukuhara, please.
Thank you very much for kind introduction. Good afternoon, ladies and gentlemen. On behalf of Kyoto University School of Public Health, I feel very honored that I'm invited to the first conference celebrating the 100th anniversary of Professor K.P. Chen. What he achieved is so great, so I cannot catch up with his achievement. So only way I express my gratitude is I imitate his bow tie. Oh, oh, this one. Okay. Yeah, what I'm speaking today is, I'm also a clinician and also public health faculty. So from both viewpoints, I'd like to share with you how fast the population has been aging in Japan and Asia. And also, we confirmed that we have to set the new goal for healthcare, which is healthy aging, of course. And we need to transform health system as soon as possible before our financial system in Japan and Taiwan fail, ruin. You know, it's really a risky situation, particularly in Japan. And my really crazy proposal is I propose a new role of a primary care physician and the team for healthy aging. And also I introduce Fukushima because I've been vice president as a joint appointment since 5 years ago. And I would like to share that Fukushima is not a special place, but actually this is a microcosm of Japan and the globe in the future. So I presided a World Health Summit, inviting NTU and Harvard University, Ichiro Kawachi and Richard Atten, Johns Hopkins, all prestigious medical academia. So this is MIT Alliance members consisting of 8 leading medical universities. It's like a G8. Instead of G8, we call it M8. But now it's M20. So they got together in Kyoto, and we plan annual international assembly of World Health Summit every year. And we created Kyoto Fukushima statement during that conference. So why we organize a World Health Summit in Japan? Because Japan is the most advanced country for hyper-aged society. Do you know that 2025 problem? That is scary to us, that old baby boomers will become 75-year-old and older. Yeah? And by 2060, we will have 40% of population 60-year-old and older, and 25% are 75-year-old and older. We are the most advanced country because we had a tragic triple disaster in March 11, 2011. And among Japan, Fukushima stood out because they have a more NCD and they are even more rapidly aging. And they have a shortage of 700 clinicians, which is 20% less than average of those in Japan. The president of Fukushima Medical University ordered me to recruit as many clinicians as possible to Fukushima from outside Fukushima Prefecture. I tried my best, but I only recruited 40 physicians from outside so far. So, as you may have seen, this is a demographic change since 1950 and 2020. Beautiful pyramid shape. This is an ideal shape for economic growth and country growth, But in 2010, it's this shape. So now we have a 25% of elderly population, but by 2050, this will be worse. And amazingly, we are full of old people in Japan. So it's called old people endemic. Look at Taiwan. Taiwan is much better than Japan. Only 10% comprises entire population, but it is a statistic from 2005. So I don't know now, And I heard that Taiwan is one of the countries that aging is happening fastest in the world now, and Portugal the next. So Japan has achieved #1 in the world in terms of life expectancy from birth. 1950, same as Dean Chen. Where is the pointer? Upper middle. It won't. Oh, I see. 60-year-olds, 77, and now 79. Female, even better, 86. My mother is celebrating the 88th birthday next week. She's entirely independent, living alone, cooking. But Japan is not #1 in terms of healthy life years, which is, 70 years for male and 73 for female, closer, because female spend more dependent life than men for as long as 13 years. That is a huge burden to the society. So, needless to say, the goal of healthcare has changed already. Longer healthy life years rather than longer life expectancy and better quality of life, and so that they experience fulfilling lives to the end of life. So Ministry of Health and Welfare reported in 2010 about the cause of disability of Japanese. The cause of disability is different in terms of subcategory of the elderly population. Young elderly is not young, but under 75. They are young now in Japan. They're supporting the society. And stroke comprises 50% of the cause of disability. So we have to try really hard to prevent stroke for younger elderly who supports the society to prevent premature death and disability. But for the super elderly, which is a 75-year-old and older, stroke dropped from 50 to 20. Instead, fall and fracture, dementia, Alzheimer's disease, and weakness are 3 major causes of disability. So it's an entirely different picture. So what are preventable outcomes for the elderly? So we have to stratify elderly people. We can't talk about, things in old people. It's a different population. For young elderly, preventable outcomes of premature death by reducing metabolic syndrome and cardiovascular, cerebrovascular events. That's what Japanese government and the public health have tried so hard over the past 20 years, and they have been somewhat successful, moderately successful to reducing metabolic syndrome and managing hypertension to prevent cardiovascular events and stroke, which is called Healthy Japan 2000 or something. But for super elderly, we have a different picture. We have to prevent disability. We don't have to prevent premature death because they have lived well enough. So it's different. Quality of living should be improved. So major outcomes we want to avoid is fall and fracture, and symptoms of Alzheimer's disease, and sarcopenia. These three are major causes of disability. Rifat Atten at Harvard School of Public Health gave me this a slide. It's from Germany. Multi-mobility is another keyword for super elderly. Like my mother is well and living independently. Still, she carries 6 comorbid chronic conditions, taking more than 10 medications. And she has 5 subspecialists. How can she manage it, She should be very busy visiting physicians. And looking at this, as many as 25%, 1/4 of super elderly have more than 5 chronic conditions like my mother. It's not unusual. So under this condition, can we continue current health care, medical care for the super elderly? Hospital-centered care, highly segmented, organ-targeted medicine. Now, more than half of the patients at clinic and hospital are occupied by the elderly. If you go to hospital in Tokyo or Kyoto, big hospital floor is full of wheelchair. You can't find a space to walk. And more than half of the healthcare resources spent for the super elderly. So multi-mobility is common. It's taken for granted among the super elderly. That's a default. That's a norm. This is not abnormal status. Super elderly should have chronic condition. So, like my mother, she sees 5 subspecialists, but if she has 10 chronic conditions, does she have to see 10 subspecialists? Obviously, our country will collapse. So what paradigm shift or transformation is necessary in Japan? Well, we still carry this old paradigm, which is find it and fix it. In Japan, we still have mass screening of employee and residents, and definitely they are over-screened. In Kyoto University Hospital, they have a rich people club, and you pay 1 million yen to be a member. Then you have hundreds of examinations, including PET scan and everything. And what you end up with 70% proportion of abnormality. Yeah? And more than 80% are false positive. What a waste, you know? And as Michelle said, you know, if you are told that you have abnormal finding in PET scan or prostate cancer screening, you know, you may be depressed and anxious, and you may commit suicide. What a waste. Well, I would say it's an old-time fantasy. We need a new paradigm that is predict risk and prevent undesired preventable outcomes. So who can prevent frailty and disability of the super elderly? Public health service, occupational physician, academic public health departments? Well, I would say 30 years ago, maybe possible, but not anymore, because we will have 30%, 40% elderly population in Japan. Well, I think maybe, this is not conclusion, but maybe primary care team can help. Why? Because, like my mother, more than 90% of super elderly has at least one chronic condition, right? Even more. On average, is 2.8 or something. Therefore, clinic is the best place to capture them, capture almost all of them in a real-time fashion, you know, get them and just do something at clinic rather than waiting for mass screening place or, you know, occupational health station. Primary care team can improve modifiable factors to prevent 3 targeted outcomes for all Alzheimer's disease and sarcopenia. How can they work on modifiable factors? 4. Well, conventionally, we try to use rehabilitation service, trainer, or, you know, bone densitometry to measure and diagnose osteoporosis and prescribe something. You know, that's a conventional method. That's fine. You know, we can continue that, but it's not enough. Some innovative measures, such as we have conducted a cohort study in Sukagawa City where Goto Shinpei went to medical school. Goto Shinpei was a former mayor of Tokyo City who rescued a big earthquake 100 years ago, and he came to Taiwan and to promote public health. And we have had a cohort study in Sukagawa for 4 years, and we found, for example, vision-specific quality of life. It's not visual acuity or visual field. We measure self-reported vision quality of life. Urination, you know, in BMJ, we published a paper from this cohort study that if you have a symptom of frequent urination with urgency, it's called overactive bladder. We can measure with a self-reported questionnaire. For example, if you go to bathroom during night less than and equal twice, if you go to bathroom for urination for 3 times and more frequently, you have 3.5 times higher risk of fall. And it can be preventable. Sleep disturbance is associated with a 2 times higher risk of fall. That is a sort of new risk factors unidentified, but we identified in cohort study of the super elderly population, and PC team may be able to intervene at clinic. Progression of Alzheimer's disease, that is most challenging in the world because there is no radical curative treatment at present, but its current goal is not to delay the onset of disease, but delay the onset of symptoms. As long as we can delay the onset of symptoms, patient will die before they develop symptoms. We know that even with a similar pathological change in brain, like amyloid, beta amyloid accumulation and tau accumulation, which can be measured with a spinal fluid currently. And our Kyoto University group has measured those density of CSF as a surrogate of pathological change in brain. And they found huge variation in terms of onset of symptoms. We call it cognitive reserve. Cognitive reserve, even with the same amount of accumulation of beta amyloid or tau, you may not develop symptom of Alzheimer's disease. That is really great. What is the measure to prevent? Maybe, this is conventional, exercise, diet, smoking, social isolation. Maybe Nintendo game to practice kanji, and challenge you the memory, recent memory, or robot, bilateral communicable robot is now available, looking at your eye and facial expression and talking to you, and it's really emotional conversation, communication may help increasing cognitive reserve. I don't know. We have to do interventional study. So finally, why we moved to Fukushima after Kyoto to organize a satellite symposium of the World Health Summit in 2015. This is March 11th, triple disaster. Well, triple disaster was really tragic. It is so-called external shock. At the same time, in Fukushima, it's aging happening fastest among other prefectures in Japan. And obviously, current healthcare system, hospital-centric, segmented healthcare system is failing. This is sort of internal shock in Fukushima. So in other words, Fukushima is a microcosm of Japan and the future of the globe. It's a mirror image of the future of your country. Rifat Atten of School of Public Health and us published this article in Journal of Global Health, and in subacute phase, incidence of death due to myocardial infarction is really high in Fukushima Prefecture. It stands out even among 3 prefectures in Tohoku, which have had similar attacks by tsunami. So this is very unique phenomenon in Fukushima. In chronic phase, look at, this is Japanese aging trend, but Fukushima is about 2 years older than Japanese community. So current challenge in Fukushima is shortage of healthcare resource, long-term evacuation for fear of radiation and social isolation of evacuees. But above all, we are so worried about unhealthy lifestyle, smoking, salt index, little exercise, obesity of Fukushima people. Yes, what have been happening in Fukushima is tragic, but it's not atypical. Fukushima is a microcosm of Japan and the future of the globe, what I should say. So we created some innovative project, which is called School for Your Health. It got Good Design Award in 2016. Basically, this is a picture. I'm running out of time, so if you're interested, please ask me after my presentation. Conceptual framework is basically self-recording. Let residents, old people, self-record their lifestyle. We believe self-recording your behavior and outcomes may change elderly people's behavior. Predictors, lifestyle, comorbidity, quality of life, and outcome is loss of independence. So this is kiosk. This old woman cannot use application on smartphone, so she comes to this kiosk to scan her homework notebook for her school for health. And this will read her record instantaneously and instantaneously feedback how she's doing over the past 3 months. And some advice, don't take too much salt. If you eat too much noodle, you have a lot of salt or something. Yeah? And this is a workshop to prevent falls. And if you can accumulate points by just recording. Yeah? And Fukushima Prefecture's Agricultural Association give you gift if you accumulate enough points. It's like a mileage. This is another incentive. So in World Health Summit, facing these 2 difficult problems, we set the 2 keywords at Kyoto World Health Summit, which is responsiveness. We have to act quickly. Time cannot wait for us. We don't have so much time left in Japan. We have to move quickly to transform existing health system, and resilience, of course. So ladies and gentlemen, I conclude that Japan is facing crisis, but your country will face the same thing in near or remote future. In Chinese way of saying, crisis is opportunity, right? So Japan and Fukushima has great opportunity to change. Without crisis, you can't change. Thank you very much for your attention.
Please stay. So once again, to express our appreciation, we have the honor to invite the chair of the committee, Professor Chen Wei-jian, to present the gifts to both of the speakers. Please.
Okay, thank you very much. So let's have the discussion session start. So let's welcome our discussant, Professor Wu Xiaoqi from National Yangmin University. The second one is Dr. and Director Teng Shaoyi from National Taiwan University Hospital. And the third one is Professor Chen Yamei from National Taiwan University, which is our own college. And the third one is from Konkan University, Professor Wangsa, sorry, here. So due to the time limit, so I'm going to ask the discussant to give brief comments or suggestions or questions for these 2 speakers. So each one have like 3 to 5 minutes, okay? So let's start with Professor Wu.
Good afternoon, everyone. First of all, I want to say thank you to our 2 speakers. They gave us a very wonderful speech. And I found that Dr. Zhang, you mentioned about the ABCD rule to check skin is very good. But from my point of view, because Taiwan have a rapid aging problem, so maybe herbs roaster is more important to Taiwan. So what will you suggest us, especially for public health workers, what can they do to let more people know about how to prevent this disease, virus infection? And that's my first question for Dr. Zhong. And my second question is for our another distinguished guest from Japan. You mentioned about active aging and healthy aging, but I more prefer the productive aging. Because healthy aging person is personal, more healthy, but productive aging, it means that maybe we can help each other. If I'm more healthier, I can help others who is get thicker or elderly to do more things. That's my first question. And my second question is Dr. K.B. Chen in the 42 years ago told us that the national health insurance is important, medical care network is important, and the primary care team, community medicine is important. And so from my point of view, I want you maybe explain more about the composition of the staffs in the primary care team. Thank you.
Okay, second one, Dr. Chen. It's open.
Okay. Distinguished guests and ladies and gentlemen, I'm Dr. Xiao-Yi Chen from the Department of Family Medicine, National Taiwan University. As a clinical doctor, I think I'd like to give some feedback to Dr. Fukuhara. In Taiwan, we know that Taiwan is facing a pretty similar situation like in Japan. So by the year of 2018, which is by the end of next year, more than 14% of the Taiwanese population will be over 65. So we're also facing a quite aging society. So the government really has to take a good attention to that emergent question. So actually, for the past 10 years, we do have this national 10-year long-term care program in Taiwan. And it was initiated in the year 2007. But unfortunately, it doesn't work very well due to various reasons. First of all, it's because lack of budget, not enough money, and lack of qualified members. We do not have that much workforce to work for that. And most important of all, there's a lack of integration between the community and the centers. Therefore, the government has formed a new project, which is called the Version 2 project, and which will sort of just make up or improve the current situations by promoting community health care and also by strengthening the infrastructure of public health and also to recruit enough trained members and also to minimize the disparity between the metropolitan and suburban areas and also to stabilize the financial resources. By making all of these efforts, we probably will have a better future. And from a primary care physician's point of view, what's the role of the primary doctors in the community? Basically, we have recognized that for a long time, and at National Taiwan University Hospital, we formed this Taida Jingfu Medical Foundation, led by President Professor Xie Bo-shen. Professor Xie is actually the leader of this working task force. So what we're going to do, we're really going to use the community doctors to form something like a group practice, which is very similar to Dr. Fukuhara just said, the PC team in Japan. So several doctors in the community form a group practice, and they will work together and take care of the community people's elderlies. And basically, they will integrate with the hospitals. For example, it's only when they're very ill, they will be referred to the hospital. By doing this mutual collaboration, we hope that the quality of care will be greatly enhanced. And that's the ideal. And in reality, how are we going to do that? So basically, we hope that as primary care physicians, we can actively participate all the activities in the communities. For example, all the doctors have to go like cancer screening, they have to participate healthcare education, and they also have to, the most important thing is that we encourage people to do home care, which is very similar concept we learned from Japan. So by this propagating this home care, we hope those disabled or very super aged elderly could have a better quality of life and die. Thank you very much.
Okay, thanks, Dr. Chen. And third one, Yame, Professor.
Okay. Good afternoon, I'm Yame. First, I'd like to thank for two speakers' great presentation this afternoon. And for Professor Zhong, I have two questions. As you know, from Chinese culture, you have mentioned that to prevent skin disease like melanoma, it's important to protect yourself from sunburn. How about this is more for women's practice, daily practice, elder women's daily practice. How do we protect men? Like for my father, he will refuse to apply any sunscreen and even using an umbrella. And all the approach you mentioned, he will say, no, that's not what men do, especially elder men. So what can we do about this? I did some homework on skin disease for elder people. I came up with this disease, and I'm kind of curious. As acral lentiginous melanoma, ALM, it happens to be more common in Asian and Black, but it's not often related to sunburn. So I'm curious whether you have any suggestions for protecting our elders, Asian elders, from this disease. And for Professor Fukuhara, you mentioned you have heard information that Taiwan is one of the countries that ages, one of the fattest aging country in the world. I think I can be the one taking the credit. I think I'm the one sharing this information to you in Berlin. And it's true. Currently, we have about 13% of elder population in Taiwan, but by year 2060, when Japan has 40% of their population ages 65 and older, we will have 42% of our population age 65 and older. So we might, one day, we'll take the #1 oldest country, taking Japan's place and become the #1 oldest country in the world. So I think we are qualified as one of the fattest aging country in the world. So now you mentioned Japan don't have time for preparing this aging population. I think Taiwan has even shorter time to prepare ourselves for this fast increasing population. How do we take care of them? So my first concern is, how do we build a sustainable healthcare system? Both Taiwan and Japan have national health insurance program, but the program in Taiwan didn't emphasize much about help elder people stay healthy. For hospitals and clinics, they welcome people to come visit them as frequent as possible so they can make more money. And from elders' point of view, although most elders, they wanted to be healthy and independent as long as possible. But I would like to share a story. This story may be a little bit extreme, but it's real and a little bit sad. One of my research team, when we were working in a retirement housing, we met a lovely elder man. And he refused to engage in any kind of health promotion activity, any practice, including doing exercise. And once we built up this relationship with this lovely elder man, he told us, because he is waiting his health and physical function to deteriorate more, so he can once become eligible for hiring a foreign caregiver. It's certain criteria in Taiwan. only if you are disabled to a certain level that you can be eligible for hiring a foreign caregiver. And he said, when that day comes, that's the day he will go home. He wants to have company at home. So for some elders, Asian elders, they might value independent but being alone less than a little bit disabled, but with company. So how do we solve this problem? This is a gap in both our healthcare system and our social care system, and maybe our cultural value about being independent and being healthy for the whole life spectrum. And I have a second question for Professor Fukuhara as well. And you have mentioned frailty screening. And it's likely that we are currently implementing a nationwide frailty screening and followed by a nationwide disability prevention program. However, our current biggest challenge is that we found most of the elders coming to join us in our disability prevention program are those relatively active elders in communities. Those people who really need disability prevention program, they hide in their home. And it's very difficult to reach this group of people, elders. Maybe you can share some of the experience in Japan and see how can we better approach these possible frail elders who don't really prefer to connect and come out. Maybe they don't have the ability to come out, or they prefer to stay in their home. Thank you.
Okay, that's good. And just keep taking notes. We still have one. Professor Wang, please.
Yeah, thank you. Good afternoon. I'm Wong Sa Lau Hasiri Wong from Khon Kaen University, Thailand. Thank you very much to invite me to join this memorable event. So I have one question for Professor Kong on the skin cancer, because it's very rare in Thailand. Thailand might experience a lot of cancer like cholangiocarcinoma, highest in the world. It's in our region, and other cancer, but skin cancer is very rare because of our skin. It's protective. But they have skin cancer that occurs somewhere else, like in middle ear or something that is caused death of many of our population that we in experience of that one. So this one, how could we educate or prevent or do something? This is very important. And then I would like to chip to Professor Fukuhara about aging population. So Thailand is the third fastest growing of the aging population in the world. It's too fast that we really do not prepare for that. And we are just upper middle income country and far behind in terms of income when compared to Taiwan, Japan, and others. What should we do, right? Because it's come too quick, and in the like national figure, it's about 13–14%. But if you go to the rural area in our Northeast region, it's 17% already. And like some small community, every years they have 100 more and more. So what should we do? Like this morning, we asked about definition of public health, the health of the population, but what? With the corporate community effort. So we try to empower the community to look after the elderly, not the older ones, the sick one. We try to make them healthy. So this one is mean we try to promote very proactive health promotion. Right now we have the elderly school. They go to school to learn like how to look after themselves to be healthy. They have exercise class. They have kind of how they really screen or check their physical and mental health. And at the same time, they promote in social really aspect as well. The other thing that we really kind of things that is important is this care or this system is not really run by the health personnel. It's really fully supported by multi-sectoral, right? The local administration, the communities, organization. We even have the community elderly care volunteer. So they do long-term care for those who really kind of do not have anyone. I don't know how you suggest, because traditionally, the Thai, and I think Taiwanese may be the same, that all of the children look after their parents. So like, if they not live together, like your Chinese New Year, you go back home, right? Thai New Year, we go home to look after them. But with the economics driven, many of the family have only 1 or 2 kids or no children at all. And then many of them migrate. So when they need care, so we divide them to be 3 levels, like we call bed-bound, it means bedridden, homebound, and social bound. How could we bring them and to like have a social cohesion? And my latest studies, we found out that those who are older than 40 years old, because we have to study those who are going to be elderly, if they have good cognitive social capital and structural capital, they are more likely to have good quality of life. So this is something that I and we really learn how to do that. But I think the experience from Japan and others could help us at what should be next, right? Because right now we accept like migrants from Japan, Taiwan to be in Thailand because of our medical hub that we look after more than 20 million foreigners a year in the big hospital in Bangkok, and they ship the people from the primary care level to the private sectors. This is something, and then this is the thing that we worried because we don't know about features, because the rested one, actually we should promote primary care. But the latest law that the government gonna try to issue is promote what we call primary medical care, that we're gonna turn our health center when we promote to be health promoting hospital to be kind of the full hospital. For sure, they will do more curative, not health promotion and situation prevention. And now it's in the process. We try to object them, but we don't know what to do and how could we get the evidence and to show them. So I need the advice and what should we do with the Thai aging society. Thank you.
Wow, you can see we got a whole bunch of big, important, well, I don't know how to answer. So let's start with Professor Tong first. Okay.
So I had a couple of suggestions. I think there were some mentions about skin cancers being more rare in the Asian population, which is, I think, been supported by literature, but we've certainly, in my experience, have run into patients, even Asian patients, with skin cancers. So my suggestions in terms of how do you prevent them, how do you catch them early is, again, I think for the acral lentiginous melanomas, it is more common in Asians. Again, I recommend using the ABCD rule in terms of looking for the moles that don't look right. One side doesn't look like the other, or they're larger than a pencil eraser is usually what we recommend. Those are the things that we think about. In terms of rare skin cancers like the ears, what do you do to prevent things like this? This is, again, most of the times that we find these lesions in the ears, they can come from, they are usually easier caught early on. I think the other thing that you want to think about is what do they do to, things that people do to protect their ears. Wide brimmed hats, so oftentimes baseball caps are not usually sufficient to cover your ears, so wide brimmed hats are very important, and particularly hats that have ultraviolet protection factor. They actually do make hats that have that, so you want to consider something like that. And sunscreen, if you can, to protect, apply in the ear. Males particularly often are resistant to sunscreen, and I have family members who will go unnamed, who are male, who do not like using sunscreen. So what do you recommend? Usually the males are probably more likely, if they are, to use other protection methods, like actually wearing hats are generally more acceptable to them. So they're more likely to do that. We also talk about other forms of protection that may be easier. Even there are sunscreens with sprays that they can put on that are quick and not so smeary. The other things that we also recommend is just good practical behaviors. If you can, don't spend your time outside in the sun too long in between the hours of 10 a.m. to 3 p.m. Or if you're going to be outside, try to be outside in the early day or dusk. Sometimes that helps them as well. And the last thing I wanted to address was about herpes zoster education vaccine, and I think that it's important to think about, as I think many of you are talking about the importance of vaccines for your patients, is recognizing that zoster vaccines now are pretty effective, and that should be starting to be part of the general conversation, that general health maintenance for many of our patients. And I think that it's even more critical for patients who are at higher risk, and not only is it for people who are aged, but people who are immunosuppressed, who are on medications that are that lower their immune system. They're often at higher risk. Even poorly controlled diabetics are at higher risk for shingles. So things like that you should be aware of those things. So those are my recommendations.
Okay, that's great. Professor Fukuhara?
I received so many questions. so please let me take a liberty of selecting relevant questions. Yes, Dr. Wu, Professor Wu, I agree with your opinion that even super elderly had better be productive, right? Productive aging. But
social isolation can prevent.
Right. But well, it's okay. It's great if they can contribute to society, but at least they don't want to be burdened, right? So this is a minimum goal, but second, higher goal would be productive. I agree. Also, you asked me about component of a PC team. I think consists of physicians and nurse and pharmacists, and very importantly in Japan now, physical therapists play a big role. Once super elderly are hospitalized, for example, with pneumonia, they can't go home as they are. So rehabilitation, physical therapists shape them up, and training so that they can go home independently. Yeah. Dr. Xiaoyi Chen, you asked me about the importance of home care by primary care team. I agree, particularly to achieve the goal of healthy aging. That it's in my slide, that experience fulfilling lives toward the end of life. So home care is very important. In Taiwan, is it insured by public insurance? Yes. Oh, that's great. That's great. Do you have a sufficient number of, I'm asking you questions. Do you have sufficient number of primary care physicians? No, it's shortage. Okay.
We do have sufficient number of physicians. In Taiwan, we have more than 10,000 GP. But the problem is very few are willing to go to patients' home, partly because the very, very low reimbursement.
I see.
Yeah.
I see. In Japanese government intentionally incentivize physicians to do home care visit. It was too much, overshot. So they started cutting down now. It's related to skipping Professor Yamei Chen to Dr. Wang Sa from Konkan University. What should be done in Thailand? That's really challenging question. Quick answer is don't imitate Japan. Learn from Japan. We spent too much money. I don't know the right answer, but probably, limit the number of subspecialist training slot and expand primary care physicians training slot, maybe to at least over 50%, like the UK. UK has been so successful by allocating slots for training. And also train and encourage co-medical primary care team, reimburse them more. That's what I can think of right now. Don't go for higher technology. But already Thailand has a very good quality of high technology care, like I know Mahidol University, Chulalongkorn University. So maybe too late. I don't know. Dr. Yamei Chen, you asked me very fundamental questions. Yeah, what if old people in Asia particularly, they don't want to be healthy, right? They want to disappear gradually, right? That's what you said? No?
Well, I believe most elders still prefer to stay healthy as long as possible. But it's our system and our healthcare system. We didn't build in any incentive for our system to encourage elders to stay healthy. In a way, our system might even prefer...
Your system?
Our healthcare system.
Yes.
Might even prefer elders to come visit them more often, as frequent as possible.
Come and visit.
Because the payment system.
Yeah.
Because in Taiwan, most of payment is fee for services.
Yeah, yeah.
So in the past decades, we just the academic person from public health, we encourage government to do DRG for inpatient and maybe shift. Dr. Yang suggests a shift to capitation. But till now, it's fee for services. That's why it will happen.
Same in Japan. It's fee for service for outpatient service. We have a sort of DRG type of reimbursement for hospitalized care. So they really shortened the length of stay in Japan. 10 years ago it was 25 days, but now it's 10 days, still too long compared to US standard. But for clinic, it's fee for service. But what I mean is it's okay as long as it reimburses prevention. But it doesn't reimburse prevention in Japanese healthcare insurance. Okay. So that's what I do next in Thailand.
Whether you have any prevention in health prevention in your healthcare system?
Yeah, after we change our system to universal coverage, so about 80% of almost 25 to 80% is under what we call UC, which is come from our tax revenues, the same way. So they pay 30 baht co-payment.
But does it reimburse prevention?
No, it's kind of allocate for prevention. Health promotion institution, we have some budget for that, like direct for that one. And so have post-audit, if you could do something like you achieve some goal, you could get some kind of bonus if you do that one. Yeah.
Very good. So to answer all the questions? No? You just select someone?
We have to have a time for...
So considerate. Okay, we
Sorry,
still
I'm
have...
playing a chairman.
We only have 3 minutes left. Okay, at least one question from the floor. Okay, Professor Yang, be short, okay?
I just one comment for deal with aging society. Encourage young people to get married and have babies. You can solve half of the problem.
But the problem is how? Young people just feel to get married.
You look at Western European countries, in the Scandinavian countries, you know, they do not have the problem so severe like Japan, Taiwan, you know, have babies.
Yes. More children.
Okay. So the first solution is more children.
Yeah,
I don't know how.
Prime Minister Abe liberated, made it free for children's education, but not from the government. He puts all the burden to the industry.
Okay. All right. Okay, here, Dr. Zin? Yes, please.
Hi, I'm Faiza from Ministry of Health Malaysia. So basically, I would like to ask Professor Fukuhara, in terms of, like now Japan is advancing in the aging population and all that. So I would like to know, how do you actually empower your young generation in terms of caring for the elderly? Yeah, in terms of maybe the education system, your incorporation of the care for the elderly module, maybe in the education system. Yeah, I just would like to know. Thank you.
Thank you very much for a challenging question. In Japan 20 years ago, we had a good tradition taking over from Korea and China that we have to respect and take care of elderly people. And 20 years ago, my wife is supposed to take care of my parents. That's tradition 20 years ago. But the government stopped that. And the nation agreed. And that's why we started public long-term care insurance. So that's one thing, not to empower young people. And also, as the professor said, we have to have more young people. It's really a dilemma because women want to have higher education. Right? So they don't tend to get married. They get married late. And Japan has a problem that even if you are married, you can't have babies, too late. So this is, I think, a universal phenomenon in the world. How can you solve this challenge? This is a really big challenge, and you need more colleagues to share the burden. Otherwise, in Japan now, one young person is taking care of 3 elderly people. It's too much burden. Maybe they may escape from Japan.
Okay, is there any question? Okay, I think time is almost up, and I believe we all facing the same challenge, just like Michelle mentioned this morning. When they have exchange of experience, then they'll learn. Actually, we're very much alike, especially facing the aging society problem, right? One more comment? Yeah. Sure.
Please look at that poster. I'm organizing annual meeting for the Society of Clinical Epidemiology next September in Kyoto. Please come.
Okay, it's non-commercial, okay? Non-commercial, free of charge.
No conflict of interest.
No problem. Okay, let's thank 2 speakers and discussants for the excellent exchange of thoughts. Thank you very much.